Second white coat. Subscribe and like. Let's learn medicine together.
Today, we're scrubbing in to solve a high-stakes neurological mystery. The clues are subtle, the timeline is absolutely critical, and a patient's life is hanging in the balance. Let's get to it. So here's the scene. A 54-year-old woman is rushed into the ER. It all started with this sudden explosive headache, and on the way here, she lost consciousness. The clock is ticking, and we need to figure out what is going on inside her head, and fast. And there it is. The first big clue comes from the CT scan. You can see this bright white area. That's an acute hemorrhage, a bleed in her left temporal lobe. Now, this isn't just a bleed. It's creating what we call a mass effect. It's literally taking up space and shoving the brain tissue around, causing a massive spike in pressure inside the skull. So what happens when the brain is put under that much pressure with nowhere to go? Well, that kind of pressure cooker situation leads to a specific and incredibly dangerous event called a brain herniation. We're about to break down the most classic type you'll ever need to know. It's called an uncus herniation. Okay, let's unpack that. The uncus, that's just the very innermost tip of the temporal lobe, is being physically squeezed downwards and sideways. It's getting forced over a tough membrane called the tentorium cerebelli, which acts kind of like a shelf that separates the top parts of the brain from the bottom parts. You can see exactly how it works right here. That bleed is pushing everything, forcing the uncus medially and down through an opening called the tentorial notch. Now here's the problem. That path is not empty. There are absolutely critical structures that run right through there, and they are directly in the line of fire. You know, in any good detective story, you're always looking for that first piece of evidence, right? The first domino to fall that sets everything else in motion. Well, in uncal herniation, that first clue is almost always the same, and it is our absolute key to the diagnosis. So, just thinking about the anatomy, based on what's getting squeezed and where it's going, what do you think is the very first cranial nerve to get squashed in this process? If you said cranial nerve 3, you are spot on. The oculomotor nerve, or CN3, has the terrible luck of running right along the edge of that tentorium. It is smack dab in the path of that herniating uncus. It becomes the first and most vulnerable victim in this deadly pressure wave. Okay, so what does this actually look like when you're standing at the bedside? When CN3 gets compressed, it gives us a classic set of signs on the same side as the hemorrhage. First and most importantly, you get a blown pupil. It's big, it's dilated, and it won't react to light. That's because the fibers that control the pupil are on the outside of the nerve, so they get hit first. You might also see a drooping eyelid, that's ptosis, and an eye that's stuck looking down and out. For anyone out there studying for your boards, you need to burn this into your brain. This right here is the money phrase. Uncal herniation compresses CN3, and that leads to an ipsilateral, same-sided, fixed, dilated pupil. If you see that in a clinical question, massive alarm bells should be going off. But the damage doesn't just stop with cranial nerve 3. Oh no. As that pressure keeps building, the herniation sets off a truly devastating cascade. Let's take a look at what happens next. You can really think of the full-blown uncal herniation syndrome as a predictable 3-step chain reaction. We've already covered step 1, the compression of CN3. Next in the line of fire are the posterior cerebral artery and then the cerebral peduncle in the midbrain. So step 2 is compression of the posterior cerebral artery, or PCA. Now this artery supplies blood to the parts of our brain that handle vision. Squeeze that artery and you can get vision loss in the opposite visual field. It's a mouthful, but it's called contralateral homonymous hemianopia. Basically, you lose the same half of your vision in both eyes. And step 3, the cerebellar peduncle. Think of this as a superhighway of motor fibers, the corticospinal tract, running right through the midbrain. When that gets compressed, you get weakness or hemiparesis on the opposite side of the body. So now think about this. You've got a blown pupil on one side and weakness on the other side. That pattern is a giant red flag that this herniation is getting worse fast. And if this whole process isn't stopped, that pressure will just keep building, eventually crushing the brainstem itself. This is what leads to coma, to abnormal posturing, and ultimately the centers that control our very breathing just shut down. It's the tragic final act if the herniation isn't reversed. Now, a totally fair question at this point is, hang on a second, there are other nerves in that area? Why is CN3 the special one? That's a fantastic clinical question, so let's clear that up.
For instance, cranial nerve 6 is famous for being super sensitive to any rise in pressure inside the skull, just because it has such a long path to travel. So why isn't a CN6 palsy the big sign we're looking for here?
And here is the key difference. A CNVI palsy can tell you that pressure is high in general, but it's not a localizing sign. It doesn't tell you where the problem is. The blown pupil from CN3 compression, on the other hand, is the smoking gun. It points a giant blinking arrow directly at the uncus herniating at that specific spot, because it's the only nerve getting physically smashed right there.
Okay, so let's put this all together. When you're faced with this clinical emergency, you need a quick, reliable playbook to run through the steps in your head. And here it is. Your memory hook is just this: 3, then PCA, then peduncle. It's that simple. First, cranial nerve 3 gives you the blown pupil on the same side. Second, the PCA gives you vision loss on the opposite side. And third, the peduncle gives you motor weakness on the opposite side. That sequence tells the whole story of the herniation as it gets worse.
So if you remember absolutely nothing else from all this, remember this one thing. An uncal herniation's first and most classic sign is the compression of cranial nerve 3, showing up at the bedside as a fixed, dilated pupil on the same side as the injury. It is the ultimate neurological red flag. So let me ask you, what other clinical signs do you see as absolutely critical warnings?